and show this in vivo. No. Show how the stand go and
Yeah.
show that. Just push it in.
So we see it goes in smoothly.
Can you put better the focus on the
Tan
on the one?
interessante de el Visible
On
Heart.
the one?
Boa tarde para todos, boa noite no Brasil. Sejam bem-vindos a essa sessão de Visible Heart, que vai ser muito interessante para todos. Estamos esperando un par de minutos que terminen de conectarse los participantes para dar inicio. Les agradecemos su paciencia y estaremos ya próximos a dar inicio. Vamos aguardar mais uns minutinhos que o pessoal termine de se conectar para a gente poder dar início na sessão.
Michael,
Paul? No, Paul's here.
Michael, Ryan,
Brian.
Ryan.
Ok, muy
Amanda.
bien. Entonces, vamos a empezar la sesión. El día de hoy estamos muy complacidos de poder contar con la participación de todos y tenemos un panel de lujo para integrar conocimientos y conceptos sobre un tema que siempre es relevante, como son las bifurcaciones durante la intervención coronaria percutánea. Esta sesión se llama el Visible Heart. Está realizada en una sesión en vivo. Tenemos conexión simultánea a nivel del laboratorio en Minneapolis. Este es el disclaimer. Realmente es una actividad educativa. Cada uno de los conceptos y cada una de las opiniones que serán compartidas en esta sesión serán absolutamente responsabilidad de cada una de las personas que las haga. Y en ningún momento hay ningún tipo de sesgo de información en relación a las técnicas y lo que vamos a compartir en la tarde de hoy. Queremos hacer una sesión interactiva, por lo tanto, los invitamos a que participen de manera activa durante la sesión con preguntas y respuestas que vamos a ofrecerles de forma inmediata y en vivo. Las preguntas se van a ir respondiendo en la medida que vayan apareciendo. Y tienen dos canales para hacer sus preguntas a través del icono de Q&A o a través del chat directamente. Y nos vamos a encargar de irlas respondiendo a medida que vamos desarrollando el caso. Quiero compartir con ustedes en la tarde de hoy que vamos a tener, como ya les decía, un panel de lujo. En el laboratorio en Minneapolis tenemos el honor de contar con la presencia del doctor Lucio Padilla de Argentina, muy conocido por todos ustedes, y va a estar haciendo los procedimientos en conjunto con el doctor Joy Rayford. A nivel del panel de discusión, contamos con la presencia del doctor Ricardo Costa. Ricardo, bienvenido. El doctor Ricardo también es conocido por todos ustedes, expresidente de la Sociedad Brasilera de Hemodinámica y Cardiología Intervencionista, y va a estar compartiendo en conjunto con el doctor Padilla, pues, interacción en relación a lo que vamos a ver el día de hoy. Y mi nombre es Alejandro Sánchez, yo soy el principal MSL para Structural Heart y Coronario de Nervación Renal, actualmente desempeñando mis funciones en Latinoamérica para Medtronic. Por supuesto, todos bajo la dirección y la coordinación del doctor Iaizzo, quien es el profesor y director del laboratorio Visible Heart. Dr. Iaizzo, thank you for having us. It's a real pleasure to share this session with you. And I'm giving you the mic to open the session and to introduce to all our attendees. So thank you.
Well, welcome everybody. It's great to be here this afternoon. It's always exciting to do bifurcation stenting studies here in the Visible Heart Laboratories. The lab is set up kind of uniquely where we actually reanimate hearts outside the body. And on a weekly basis, we'll reanimate swine hearts, on rare occasion, actually human hearts. So if you look at one of the cameras here, we actually have a view of the heart beating outside the body in a native sinus rhythm, where you can look at the hemodynamics, and then we can actually look inside the coronaries and that's the visible heart aspect. We can actually look at the coronary osteas. Right now, there's a camera view of the left main, and you can actually see the guide cath, and I have a 2.4 millimeter endoscope down, and I can view then bifurcations. And this is a big team effort. So if the grad students want to come in here, we've been doing this now. We have a large collaboration with Medtronic. The collaboration has been going on for over 27 years, which is their longest standing academic collaboration. And this is a team effort. So it takes a team to be able to get an animal in the lab, cardioplegia the heart, then reanimate it. These hearts will stay viable for some 5 to 7 hours. So this is the team, PhD students.
Can you
here in the
come
lab.
here to see?
Why don't you say your name quick?
Hi, I'm Brian
Yeah,
Adibal.
Brian.
Yep,
Camera
right there.
Okay, camera.
Linda, the boss.
I have Neil Dillon. Michael Blake.
Anthony,
And then we'll introduce our operators here in a second, but one of the things about the Visible Heart Lab doing a reanimated swine study is that the heart's removed, and this is your opportunity to test new things. This is an opportunity to do something incorrectly just to see the result, or it's also your opportunity to visualize a perfect bifurcation procedure. These are vessels, and the coronaries of the swine are very similar in anatomy to the human heart in dimensions. However, they have no disease at all. There's no disease, very compliant vessels. So if we size the vessel and we say it's 3.0 diameter, we might upsize the stent to 3.5 because we don't want any migration of the stent. But if we wanted to see undersizing, we could do that. And again, this is a kind of a non-stress situation because you've got a reanimated swine heart here on the table. And it's a really unique opportunity to compare multimodal imaging. We have fluoroscopy, we have OCT, and we have the direct visualizations. So with that, I'll turn it over to our operators today, and you can introduce yourselves.
ok. Gracias a todos, Ricardo, Alejandro. Estamos acá con York y con Paul y todo el grupo. La verdad que primera vez que vengo a Visible Heart y es impresionante todo lo que uno sigue aprendiendo. Así que vamos a comenzar con un caso que me gustaría mostrar la angiografía, si la podemos ver. No sé si se puede ver en loop la angiografía. O si no, no sé si llegan a verla.
Can you see the angio of the LED?
Ricardo, Alejandro, do you have return?
Oh, we can see
Ricardo,
it.
you
Perfect.
are mute, Ricardo.
Okay, now I think you can hear me, right?
Perfect.
Yes.
Oh, yes.
That's great. We can see you very well. We can hear you very well. And just to say hello to you, Lucio, and the team there, and especially to Professor Iaizzo. Last time I was there, so it's really great to be here on the other side. And we learned so much in this unique visible lab. It's a really impressive, fantastic setup. And Lucio, we can now see the angio as well. I know you have planned to show us, to demonstrate some nice demonstrations about the techniques, and tell us what you wanna show us.
Well, first of all, we're going to go how to do or to simplify a complex PCI that may be daily PCI. So first of all, we're going to try to start with a provisional PCI technique. So the idea is we have LAD, 2 diagonal branch. As you see, we are going to go with the first wire to LAD, second wire to a second diagonal branch. And then what happened with the stent, choosing, as says before Paul, we are going to show, first of all, the OCT, with Amanda that we have done the OCT previews. And Amanda, the idea is to show how is the diameter distal to the second diagonal branch. Then what about the diagonal branch? And then what is the size in the LAD previous to the diagonal branch? So as Paul says, if we have in this case an LAD after the second diagonal branch of 2.5, we're going to choose a 3.0 stand, you know? So
Not sure if
so-
you can see the OCT ones.
can you see the OCT?
Yeah, we can see, we have here a mosaic here that we can see for those who are following us and just started to follow this session. We have in the left upper side, you can see a direct visualization of the bifurcation. We see two wires, one in the main vessel and one in the side branch. And then in the middle, we have the angiogram. And then in the top right, we can see the OCT. I'm sure we can magnify here when we see focus in one of these images. Then in the mid portion here, in the left side, you can see the guiding catheters and where the camera sees. You see the aorta opening here. And then, Lucio, we can see yourself and our colleague here working. And we can also see the setup of the entire room. So basically, we can see everything. So the OCT you mentioned, you're now distal to the bifurcation, correct?
That's
Yeah.
correct.
Okay.
So Amanda,
yeah, go ahead.
no, it's 269, the diameter after the second diagonal branch. And then Amanda, we're going to go in the side branch and try to measure that. There is the second 232, the second diagonal branch, and proximal to that, we're going to measure the LAD 3.
Proximal to the
So
bifurcation, right?
yes, the idea, as Paul say, in the peak scenario, we need to choose if it's 2.5 distal to the second diagonal branch, we're going to choose 3.0. So the idea is to show, and now I want to let Paul say, what is this camera that we have inside? What is this that we can show the two wires? I don't know if Paul can tell us this.
Yeah, we can see now the big screen here. We can see exactly the bifurcation. We see the flow divider, the left of the carina, and we see one wire in the main vessel in the left side and one in the bifurcation. We can see the angulation here, more angle, the wire into a diagonal branch. Yeah, it's very clear.
Can you explain all what
Yeah,
this?
so this is a 2.4 millimeter video scope. It's a liposcope here. And, you know, you can see it in the fluoro as well. So I'm about a centimeter back from the bifurcation. That's the focal distance. And if something goes wrong, you always blame the cameraman, which is me. And Ricardo, we wish you were here as well. We're glad you're online, but you got to come back soon.
Yeah,
So we're going to show this,
Thank you.
Ricardo. So we're going to do a practice, a scenario. We're going to go with fluoro now and to see how I choose a 318 stand in order to show what happened with this. So we
So
have
we can see the stent going here into the bifurcation, crossing, of course, the side branch. This is a 3018. Which stent is that, Lucio?
this is a Frontier. This is a only Frontier 318. Why we choose this? Can you see where in the screen where the stent is going into the main bifurcation branch? Can you see that?
We can see very nicely. It's always impressed me how thick is the wire, right, Alejandro? You think the wire is very thin. You see the thickness of a wire, it's larger than the struts of the stent. It's very impressive. That's why sometimes
Yes,
we get
yes.
so much problems with that wire into the
Yeah,
vessel.
absolutely. I think
Yeah.
it's very interesting because now we can see live what is really happening inside the coronary vessel when we are performing a PCI. So this is amazing, and this is a unique opportunity. And absolutely, I agree with you, Ricardo. I think that the guide wire occupies a nice space inside the coronary vessel, and compared with the struts of the stents, we could see that this is it's very tight. So it's very nice,
So
and it's a nice
the
opportunity.
idea,
Yeah.
Yeah.
the
So
idea is to
Lucio,
show how.
one first question. You
Yes.
are advancing a stent. This is supposed to be very didactic. So how do you size a stent that's going to cross a bifurcation?
So I first of all, I put both wires. Second, I have the stent that is very good. The sensation that it goes very easy, as you can see in the screen. I'm going through the side branch, and I will leave 10 millimeters proximal to the side branch. And if we can see better, Paul, the side branch and the bifurcation, we're going to develop now. We're going to develop, go.
Yeah, and the diameter, Lucio, how do you size the diameter of a stent to go into the bifurcation? You
Millimeters.
take the distal reference, the proximal reference, you take a mean. How do you size that? What do you recommend?
As always, we took the distal reference of the artery as the diameter of the stent. So this artery is 2.5, but in peaks, we need to go 0.5 more. So
Okay.
we use, in this case, 3 per 18 in length. And now we're going to, we deploy the stent. I want to know what about is the stent now, how, if the stent is well opposed or not. So I'm going to take out the balloon. Yes.
Okay.
If
Paul
you
will
allow
tell
me,
us.
That's a
if
very,
you
I think
allow
that's
me,
a very
Lucio,
important, that's a very important point for those who are following us. You always size a bifurcation according to the distal reference, because otherwise you're going to cause trauma into the distal portion. However, as we know, this fractal geometry, proximally, Lucio, maybe is not that well opposed, right? What do you see there?
yeah, I would
Well,
like to summarize at this point that we are performing a provisional stent bifurcation, right?
Yes.
This is a provisional technique. Yeah, so this is the stent in the main branch, and we can see here that there is a trap guide wire between the stent and the coronary vessel wall. And also about was Ricardo was asking regarding the apposition of the stent, considering that it was selected, as Dr. Lucio said, according to the distal vessel diameter. So we can expect that the apposition of the stent proximal in the main branch could be incomplete, and that's what are we seeing here, right?
Yes, if you can see, si pueden ver en hora 11, pueden ver la guía del side branch que está atrapada con el stent. Yo ahora voy a intentar hacer una maniobra para ver si pueden ver la guía para demostrar que el stent no está bien aposicionado. That to go with a wire to show that the stent is not well opposed. I will try to go there with a third wire in order to show I'm here with a knuckle, and I will try to show.
You did not do the pot, and you're going to try to go with a third wire and recross into the side branch, correct?
No, I want to go to with a third wire in order to show in the floor.
Now you can see it.
Nice.
You can see now.
Yeah. Very nicely demonstrated. You're going under the struts. Imagine if this is happening at left main. So you're going under the struts because it's not fully opposed, and the guide wire just goes straight there. You see how thick is the guide wire again, and you if you push too hard, you can deform the stent, right?
You can see now that I go by 9 hour with the third wire, so the stent is not wettable. So the idea is, how can we optimize, cómo podemos optimizar this PCI? What is the importance of the pod technique? Yeah, so I'm going to take out the third wire. I want to show that, that was very nice. And now we're going to do a pod. Vamos a hacer un pod con el tamaño real, luego de haber avanzado el stent implantado, que angiográficamente luce muy bien. So, we're going to do the pod.
I want to stimulate. We have 150 people connected from all over Latin America. This is really fantastic. And please send your questions, send your comments. We want to make this interactive. I see some friends here in the listing, so I'm going to start to call by name if they don't send questions, viu, Alejandro? But please send questions and comments. So, Lucio, you planning to do a pot? What is the size of the balloon that you have selected to the pot?
3.5 by 8 millimeters. 3.5. So, related with the OCT.
3.0 in the distal portion. You size by OCT, so you select now 3.5, and let's see how we can position this exactly where it need to be. Show us.
Okay, so you can see by the screen, and you can see how is the balloon going into the first part of the stent. Do you see that?
Yes,
Pueden ver el balón.
You can see in the camera and also in the angiogram. Yeah, we can see it.
So the idea is to do a pod. So we are not going to do a pod. We can go with the camera inside the bifurcation to see what about that. I don't know, Paul, if we can go ahead with the camera more. See.
So Lucio, very important. You demonstrated before, if you had a wire, third wire going under the struts, and you try to go with the balloon for the pod, you'd cause a big distortion, right, in the proximal segment.
I can destroy the stent and the platform. So now we're going to create with doing the pod technique. Vamos a insuflar 18.
Puedes compartir con la audiencia cuál es la posición correcta para hacer el pod, la posición del balón.
Bueno, el punto distal está donde está el origen del ramo del side branch, ¿sí? Ahí pueden ver el punto distal del balón. Vamos a insuflarlo de vuelta y vemos que igualmente hay todavía unos 4 o 5 milímetros de balón proximal, que eso también hay que dilatarlo, porque tiene que quedar muy bien expandido. Así que vamos a ir.
If you don't have a too long balloon, you should do first at the level of the carina, just at the full divide, and then you can bring back and make sure that you have also the proximal end of the stent, right? Whereas that's very nice.
See in the video that's how I inflate and we deflate now the balloon, you know? And what about now with the stent and the position?
No, it's completely different. Now it's fully opposed. Lucio, there's one question here. Should you always do the pot if
we should always
with a wire, with a J wire into the side branch, or you should remove the wire, you re-access, or even before re-access, you do the pot? What do you recommend?
Depende lo que yo tenga en la bifurcación. Si en la bifurcación y en el ramo diagonal está comprometido y es un ramo importante, llamémosle importante a tener un ramo mayor o igual a 2.5 milímetros y de más de 70 milímetros de longitud, eso sería un ramo importante para proteger. If we have lesion in the diagonal, I can remove that. But if not, I leave the wire, I do the pot, and if I have any complication of the side branch, I can reaccess. So the idea now is to show with the wire if I can go between the wall and the stent, and after that, to reaccess with another wire to after the pot, you know?
Yeah. So
O
sea,
very nicely, we see the carina. So
público-
what
Tenemos
you're
otra
telling
pregunta
us,
del público.
yeah,
Perdón,
what you're
Ricardo.
telling us, Lucio, is that if you have a wire into the side branch, you can do the pot with a wire, gel wire, and then after you can remove the wire, right? It's okay to do that.
Yes.
So you can go high
Tenemos otra
pressure, you
pregunta
do
del
your pot,
público.
and then,
So,
yeah, go ahead, sorry.
tenemos otra pregunta del
Alejandro.
público en relación a la longitud del balón. Lucio, ¿qué longitud consideras para escoger el balón para hacer el pot? ¿Va desde el borde proximal del stent hasta el origen del ramo lateral o puedes jugar
Yeah.
allí con las distancias?
The idea, Alejandro, is to go from the side branch to proximal. Or every time go from distal to proximal and to cover all the stent, all the proximal stent from the side branch. Entonces siempre ir desde el ramo de la bifurcación hasta el origen del stent. Y ahora la idea es, si se hubiera complicado el side branch, ¿nos ayuda el pot o no nos ayuda el pot? So, the pot proximal optimization treatment es optimizar el segmento proximal del stent. ¿Nos sirvió para algo o no? Creo que después vamos a mostrar qué estamos haciendo en Latinoamérica. What we are doing in Latin America, that we're going to show afterwards.
Another question here de Luis Rafael Soares Urdaneta, our colleague here. Usted já respondeu, you already answered, and when to have a protection, I think you already protect the side branch, and if in which cases to do an active protection. So tell us what is an active protection, una protección activa de la rama, ¿cuándo hacer?
Si yo tengo una rama con una lesión mayor o igual al 70% o longitud más de 10 milímetros de lesión, tengo que tratar esa rama primero y después decidir si dejo esa rama con balloon o drug-eluting balloon o necesito una técnica 2 stent. En este caso, me parece que es un ramo de por lo menos 2,5 milímetros, ya medido por Amanda here by OCT, y que mide por lo menos unos 60-70 milímetros. Por lo tanto, es un ramo que no puedo perderlo. Entonces,
Perfecto.
de ahí la necesidad. En mi caso, me gusta ir con 7 French, 2 wires y protect the second wire. So the idea now is to show. Yes.
Okay, no, perfect. So, Paul, can you show us exactly at the takeoff of the side branch inside, so we can see where the wire is exactly going to the side branch?
First of all, I want to show now. Paul is showing the third wire that is outside. I'm trying to go between the stent and the wall, and I couldn't because
It's
of
fully
the pot.
opposed. It's fully opposed. Yeah.
Yeah, fully opposed. So this is very good. So now Paul is
So-
going to go through the stent. I'm going to try to go near the carina. And we are trying after the pot if I can recross that or not.
Okay, so we see very nicely the carina. We see at the right the side branch, and we see the
yes.
wire going. Yeah, very nicely.
You see how
So,
can I cross?
Lucio, that's a lot of discussion nowadays to go in the distal cell, proximal cell. Where are you, and are you comfortable with this? And how important is this for provisional approach?
For me, I'm very comfortable. I show now that after the pot, we can cross because we have the stent very well opposed. And now what I want to do is to open that cells. For example, if I have a ostial or proximal diagonal branch disease and I have to do a bailout. So this stent is good enough to me to open. Can I see if the stent deformed or not? Entonces quiero ver si puedo recruzar a través de esa guía que acabo de poner. Vamos a ir con un balón 2.0, 2.0 balloon, please, semi-compliant.
So, Lucio,
y para-
when we have a real case, of course, unfortunately, we don't have such a wonderful image by Paul, but we have IVOS, we have OCT, and we have angio as well. So how can we use even the angio to understand if we are in the best, let's say, point for recrossing? If you're doing like a left main provisional and you're recrossing to the circumflex, how can we do this?
What I do, Ricardo, what I do if I don't have OCT or VIVUS, that there are a lot of centers that can do it because of economic issue or whatever. I do a stem boost or a stem beast, and I try to do stem boost or a stem boost enhanced, stem boost contrastado, y me permite ver la entrada distal de post-pot, so I can show after pot where I can cross distally. Now, I'm going to show if I can go with the balloon through the strut that is close. So I pass with a wire. I have one wire cross another wire, a third wire, una tercería, y voy a intentar ver si puedo pasar, y lo vamos a ver con la video. Fíjense ahí que en la video.
Lucio, one question. If you're going with a third wire, or even if you want to do the switch, do you recommend to always leave the wire, J wire, into the side branch before recrossing, or it's okay to remove the J wire and try to advance again into the side branch?
I'm going to remove the third wire after I cross the balloon, before inflating the balloon. I'm going to retire the wire, but now I will use it as an anchoring wire, you know?
Okay, so very important tip as well. You should ever leave the wire into the side branch, the J wire, and only remove when you have your recrossing the side branch, and then you can remove the J wire. So that's a very important tip. So I see you trying to access with the side branch balloon now. Which balloon are you going, Lucio?
Ricardo, this is a 2.12 balloon, but look at the video and you can see going through the strut, the balloon now, the proximal and the distal point, you know?
Yeah.
You can be by Andrew. ¿Lo ven?
Yeah, we can see.
Sí, se ve perfectamente, Lucio. Y se ve que pasa sin resistencia.
Yeah.
Sin resistencia alguna. Ahora voy a retirar la guía lateral.
Which balloon is that, Lucio? What brand is that balloon?
El balón es Eufora de Medtronic.
Okay, so it's a semi-compliant balloon, Eufora 2.0 by 12, right? And it's going nicely, you know, across the struts after you wire. Okay. So what are you going to do now?
I'm taking out the wire that was jailed, la guía que estaba atrapada, la estoy retirando. Y entonces ahora lo que vamos a hacer, what we are going to do is to insufflate and to open the struts. This stent have the capability to open until 5 millimeters the strut. Y this stent from 2.0 can go till 3.5. So I'm now with a 2.0 balloon. We are going to open 8, 10, 12. The idea is try to go with a balloon.
Una pregunta, Lucio. ¿Cuándo decides utilizar el pot, side branch pot, y cuándo decides utilizar el stent kissing balloon pot, perdón, el kissing balloon pot en estos casos de provisional? En este caso estás haciendo un pot, side branch pot, ¿correcto?
Sí. Ahora hicimos el pot, hicimos el side branch, y ahora vamos a repetir y vamos a hacer.
But you see, it's interesting to see that you do see some, concentration of metal into the main vessel. So it will be interesting to see if a new pot, as Alejandro said, side pot, or maybe a kissing balloon could make this architecture, better distributed in terms of the metal there, because you can nicely see it's more concentrated now at the takeoff of the distal main vessel.
5.8.
358.
First of all, Ricardo, see what Paul is showing us how we open the cell of the stent after the 2O balloon. We don't want to be so aggressive, and we don't want to do nothing more. If I want to treat with another thing, that diagonal branch, I will try to use drug-eluting balloon. In this case, if I have a residual lesion more than 30%, or dissection more than B, o TIMI flow less than 3, o sea, lesión residual más del 30%, o una disección más que B, o un TIMI flow menos que 3, ahí vamos con stent. Si no, yo considero uno puede decir pod, side pod o pod, kiss pod. La idea es que no se deforme the proximal stent, ¿sí? So the idea is
Lucio,
to do...
do
¿Qué
you think in
opinas
the real
de la
case,
cantidad de struts
watch-
que están arruchados en el ramo principal? Después
Yeah,
de la
yeah.
bifurcación justo a nivel de la carina. Hay una concentración de stent que aumentó un poco, era lo que comentaba Ricardo. ¿Qué opinas en relación a eso?
Yeah, e
No,
uma
vamos a
pergunta, Lúcio. Vendo o que você está indo agora, você ficaria confortável de deixar o caso assim, terminar o caso assim?
100%.
Ok,
La idea es provisional stenting como primera opción de angioplastia. Can we go?
sim. O que está sendo agora, Lúcio?
We are doing a pot with a 3O 8
Okay.
millimeters 18 atmosphere.
Então, acá
in the
é
proximal.
a estratégia pot, side pot. So, 3.5 by 8 in the pot, non-compliant, and then a 2.0 by 12 in the side branch. How many atmospheres
Yeah.
did you go, Lucio? How many atmospheres
18.
did you go in the side branch? No, in the side branch
18.
first.
No, 12.
12.
Side branch was
And
12.
now, and
Because
now
we
you're
don't,
going pot again 18.
Ricardo, a take-home message. We don't want to dissect the side branch. We want to protect and to leave open the strut of the main vessel stent, you know? That. So
Okay.
we are going to see now, what about with the Paul is looking at,
Yeah.
showing us, what about the proximal part? Look at that.
Oh, it's completely
Perfect.
different. Yeah,
Nice
it's completely different.
match.
Yeah. Yeah.
All well opposed. So
Yeah.
that is what the ABC of the bifurcation of provisional stent.
Yeah.
So I want to know that, and we want to show that. If you want, we're going to finish with an OCT for the main, and to see not only with the video but with OCT. What about if we have
So-
the?
So
We
Lucio,
want to
in your practice, and I just want to say hello here to Dante Pazanese. We have all the fellows there following in the room there. I'm sure that other institutions doing that as well in Latin America. So we're close to 200 people now connected. So Lucio, are you comfortable to do a pot, side pot, or you think if you're dealing with a big bifurcation, let's say a left main bifurcation, circumflex involved as a side branch, we should always do kissing? Do you have this answer?
In that situation, I will do always kissing, pot, kiss, pot. But in this situation, I feel comfortable to do pot, side, pot. We can see what we are doing in LATAM in the registry in few minutes. But
But
if
the
we-
important message here, you always need to finish with a pot, correct? Always.
yes, always
The
with a
last
pot.
procedure should always be the pot.
Can you tell me the
Camera back a
camera,
little bit.
please?
Fine.
Pot or repot, ok. Again, todos que nos acompanham, por favor, mandem suas perguntas e comentários. Queremos ser bastante
Yes.
interativo. Se tem alguma pergunta, um comentário, por favor. So now we're going with the OCT, correct?
Sí.
Paul, if you could
Estoy
have the
tratando.
OCT in the big screen here, so we can see it better.
Good.
So I think you should do it. Because there's metal on the side.
I do a pot, side, pot. We don't do a kiss.
Yeah.
So
we see the
Amanda,
OCT, but it is small. So maybe if you could have in the big screen, the OCT.
can you show with a big screen the OCT, please? Can you open that?
Yeah.
We can control the main screens, but I would have to.
Oh, yeah.
Yep, no.
Yeah, perfect. Okay, so Amanda, you want to comment here?
Amanda will show from distal to proximal and to see what about the side branch. So this we
Okay.
are distally. So do you want to tell something, Amanda, or?
Yeah. We just saw the side branch coming
Sure.
and yeah, go ahead, please.
Yeah, we can see the stent struts are well opposed. There's no sign of dissection. And coming to the proximal part, the pot really helps expand the stent to the diameter of the actual vessel. And
Yeah.
we look
Can
at
you go back to the
can we-
side branch takeoff? Side branch takeoff?
Yes.
yeah.
Yeah.
There.
So it's coming here at 8 o'clock. You see how it's nicely open. We don't see any strut distortion. We used to see that depending on the technique applied. And you did just perfectly all the steps, Lucio. So it's very nice to see how it conforms to the geometry as the merging of the vessels, come to the proximal carine, which is a conical shape, and then becomes to the proximal part of the vessel. Very circumferential because you did a pot at the end. So it's not oval if you don't do the pot. And also how well it's you see the OCT software, you can see the white dots here. You can detect the struts. They are well embedded into the vessel wall. So it's really nice. And if you can go back to here, just to take off the side branch, you can also do some 3D reconstruction. You can also measure the takeoff of the side branch. Maybe you want to show us here. Yeah, this is the flying through.
Congrats, Amanda, that she's a very great operator of CTO, and here he's working with us from the morning, doing a lot of cases. So thank you very much, Amanda. And
this is
there
perfect.
you can see.
You see the flying through, and what we saw direct in the image, the camera by Paul, the struts and how they're distributed, we can see by OCT. So it's very nice to correlate what we see inside the pig's heart and now by OCT. So we should remember this when we're doing a case. It's fantastic.
Yep.
So can you measure that, Amanda? Can you measure there, Amanda?
We're going to measure now. Let's.
So that's one question here. That's for you, Alejandro. They're asking if this program will be recorded. I would say yes. This is part of the SOLACI medical education program, but you want to comment? Yeah.
Yeah, I already answered the question in the chat.
Okay.
I just wanted to point out that there is just one strut in the ostium of the side branch. So it's a very, very, very nice result after the dilation of the ostium of the side branch. And also we can see after the carina that the apposition of the stent in the side branch, in the main branch distally to the side branch is very well opposed too. So I think that this result is very, very good. And I just want to congratulate Lucio because this is a very teachful case. And these images are very, very nice.
Congrats to all the team here in Minneapolis. I'm amazing here because I never believed that I can work with a so good team and with guys. All of them knows what they have to do. So I feel very comfortable now. And thank you very much. And we can see in some minutes, perhaps, Ricardo, you can continue with Keys, and then I can tell you some info about what we have done now in what is our data in LATAM that
Sure.
you have.
So we can share here some. Can we do that, Alejandro? Share some information here, or what do you recommend?
If you want, we can talk now. We have the info to present the LATAM BIF of what we have did just some minutes ago.
Yeah, of course.
Okay.
I think it would be awesome. It would be awesome.
Please go ahead.
taking
And then following,
advantage
I
that
show
we have a
about
lot
the
of-
keys trial.
Yes.
Yes, please go ahead.
Nikki, please, can you show and present my presentation of the LATAM BIF till last night? So Thank you very much, Marcelo Wood, because he has been working analyzing all the data and he sent us all the information of what about we are doing in Latin beef in bifurcation. Marcelo Wood is the coordinator of the Latin bifurcation registry. Nikki, or here you are next. 44 centers, 758. So the location of the
one back. You mentioned what?
Back, please.
Back.
Back, Nikki. Back. So this is
okay. Yeah, you're saying, yeah, please.
44 centros, 1,758 pacientes hasta ayer. Quiero destacar al Dante Pasanese y a todo Brasil que han involucrado al paciente número 69, por lo que tengo en el registro, hasta anoche. Así
70,
que vamos para adelante.
70 ahora.
Perfecto. Next. So, what are the characteristics of bifurcation? What you are dealing? ¿Qué estamos haciendo en bifurcation? Next. Entonces, la localización, sobre todo, en la descendente anterior, como lo ven abajo en amarillo, la mayoría son bifurcaciones de A con 2 diagonales, 51% próxima. Next. Next, en cuanto a las bifurcaciones, fíjense, 111, 60%, 101, 6%, 011, 17%, próximo, next. Next, Nikki. ¿Y qué estamos haciendo como approach? ¿Sí? Side branch wiring, yes, 90%. O sea que cubrimos, como hicimos recién, al side branch. Próxima, next. Preparación de placa, sí. Main branch, la mayoría. Side branch, solamente 50%. O sea que solamente preparamos la placa cuando está comprometida en un 50%. Next, Nikki. Y ahora lo que pueden ver es estrategia inicial, provisional stent, yes, 74%. Bailout stenting. Y POT, fíjense ahí lo que estuvimos haciendo recién. Solamente POT, 57%. POT, side POT, 6.3%. POT, kiss POT, 11.2%. O sea, total, 75%. Estamos haciendo en nuestro registro el 75% terminando la bifurcación. Próxima. Next. ¿Qué pasa cuando tengo un bailout? 8.3%. No. ¿Cómo termino la técnica? TAP, 56%, T-stent, 14%. Cuando hay un bailout, la mayoría porque hay un shifting de placa, una estenosis residual. Next. Y esto es un poco lo que vimos recién. Next. Wire, next. Predilatamos ambas la lesión. Ponemos el stent. Stop there. So you can see there that the proximal stent is underexpanded. So this is what we need to do now. Tenemos que hacer esto. Next, por favor. Tenemos que hacer el pot. Next, Nikki. Next, please, Nikki. So, ahí está el pot. Y fíjense cómo yo voy a abrir con esta técnica. Next. La celda para después sacar la guía del side branch. Next. Y avanzar la guía hacia el side branch y ya terminar. En cuanto a next, please. A two stent, estrategia con 2 stent desde el principio, 74%. Y fíjense con crash o DK crash en la mayoría. Next. Y estos son los stent. En este caso, estamos acá sponsoreándonos este gran evento con Medtronic. Fíjense cómo el Resolute Onyx y el Resolute Integrity es casi un 22% del total de lo que se ha usado. Next. Y en cuanto a Drug Eluting Balloon, 10% en el side branch. Next. Y fíjense la utilización de IBUS o imágenes, 23.7%, 1 de OCT, 2 de FFR. Bajo. Next. Eso es si lo dividimos en unprotected left main 56%, no unprotected left main 18% de IBUS. Next. Eventos intrahospitalarios muy bajos. Next. Y esto es un poco el mensaje final, cómo individualizar el approach. Next, por favor. Fíjense hacia la derecha. No. Previous. Entonces, provisional stenting lo hago cuando tengo, como lo pueden ver ahí, una lesión en el side branch disease, menos del 10% de longitud y que sea menor a 2.5 milímetros de diámetro. O que tenga un left main menos del 70%. ¿Cuándo utilizo otra técnica? Culot. Cuando tengo el side branch y el main branch de un tamaño parecido. ¿Sí? Y después, cuando tengo que hacer un tap o una técnica en T, cuando el ángulo de la bifurcación es bastante amplio, entre 90 grados o un poco más. ¿Y cuando tengo que hacer un decay crash? Cuando el side branch tengo dificultad para acceder, o la voy a tener, o tiene un ángulo muy complejo para hacerlo, o el side branch y el main branch hay un mismatch. Por ejemplo, un side branch de 2.5 y un main branch de 4. Eso es un poco. Next. Si cualquiera quiere participar en el registro, solamente manda un mail ahí. Y finalmente, next, please. Les quiero agradecer a este grupo. Muy bueno. Thank you very much, Minneapolis. Thank you very much of this. And we're going to try to continue.
Lucio, fantástico.
Yeah.
Acabei de ter uma atualização de nosso Research Fellow, Silvio e Dante. Estaremos hoje com 74 casos. Já teremos 5 centros ativos.
Impresionante.
E teremos o plano de passar de 10, talvez 15 centros nos próximos meses, para contribuir. Eu acho que todos que podem, é um registro muito importante para toda a América Latina. Lúcio, duas coisas que I'll speak in English so they can follow. Two,
Yeah.
I think, important things coming from our region in this registry. Of course, you're always going to argue maybe that some site selection, participators, not everybody, but nevertheless, the rate of IVUS use in left main is even higher than Rolex. This very important European study, which was below 50, we were 57%. And
Ricardo.
I think that's very impressive. And also in the United States now, the level of the percentage of use in intravascular imaging, after all this more recent evidence, is around 17, 18% in the country. So in the registry, it's about 17% in non-left main. So I think we should be happy for that. And I think the quality of the work that's been done in Latin America, it's definitely improving. And that speaks for the good results as well of the registry.
Okay. I don't know, Ricardo, if you want to continue with this or you want us to continue.
Yeah, so I can present now very shortly as you get prepared for the second case. I will share here my screen. Okay, Alejandro?
Preparing the presentation.
Okay.
While Ricardo is preparing the presentation, Lucio, I would like to ask you a question because we saw that there is a use of drug-eluting balloon in side branch in some bifurcation cases. So what do you think is the indication of using drug-eluting balloons in these cases? Could you hear me, Lucio?
I'm
Lucio?
not sure if he's hearing. Okay.
If you want to this, we are okay.
Okay, so my question is regarding the use of drug-eluting balloons in the side branch when you're performing a bifurcation, PCI. So when you decide, or what do you think could be the indication of using drug-eluting balloons in the side branch or even in a native 001 bifurcation, for example?
First of all, if the side branch is important side branch or not. If I have 2.5 or more or equal to 2.5 or lesion length of 10 millimeters, but the length of the side branch is 70 millimeters or more,
This so
for me, it's a very important side branch. So if I do a very good preparation of the plaque, that is to say, lesión residual menos del 30%, flujo TIMI 3 y disección no más que B, uso balón con droga, 100%. Porque está demostrado que el balón con droga, y ahora lo vamos a estar publicando en la revista española de cardiología, el balón con droga produce un remodelado positivo del vaso por el paclitaxel y que eso se demuestra a las semanas y se ven los resultados y angiográficamente y técnicamente los pacientes andan mejor, por lo menos en lo que hay en la evidencia mundial y en lo que nosotros tenemos de la data que hemos realizado.
Okay,
Muchas gracias. Ricardo, adelante.
¿Usted ve los slides?
Sí, se ve perfectamente.
Okay, so keys is these are some slides that we have put together by Medtronic, who sponsored this study, but this was a lot of discussion about this study was presented last year at the EuroPCR. Professor Bernard Chevalier was a principal investigator, a recognized leader that developed many techniques for bifurcation. So this was the first randomized trial evaluating the impact of no side branch treatment, so no touch in the side branch, versus a side branch treatment. So as you can see here, bifurcation successfully implanted with main branch stent. So this is a provisional approach, including a patent side branch, that's important, with no flow reduction or any signs of ongoing ischemia, any Medina classification other than 001 in side branch greater or equal to 2.25 millimeters, were randomized for no side branch inflation, so 303 patients, versus side branch inflation. It could be a pod, side pod, could be a kissing balloon, 314 patients, all treated with the Resolute Onyx DS. We're going to also show you some interesting features of this device for bifurcation. The primary endpoint, interestingly, was per posterior MI at the chart. So basically, you're trying to do something very mechanistic and see the acute impact in terms of safety. And also some other endpoints would include more longer-term follow-up and then target vessel failure, TLR, and stent thrombosis as well. So here are the comparison between both groups. Nothing calling much attention here. 27% diabetes, previous MI 14 versus 28%, so more in the side branch inflation, and previous PCI also more in the previous PCI inflation. As for the lesion characteristics, LAD about 80% of the cases, radial access close to 90% of the cases, 6 French close to almost more than 95% of the cases, and here the side branch reference diameter, distal reference in the side branch, side branch reference diameter, about 2.0, stenosis about 30%, and side branch lesion length about 4%. So it's a very short, focal, and non-significant lesions into the side branch. And that's exactly where we need to discuss, should we treat or not? So in the group that had side branch treatment, 4.5% require an additional stent implantation there in the provisional approach. When there's no side branch inflation or treatment, only 0.3% require a stent because the result was suboptimal. And if you do a side branch inflation, you ended up with prolonged procedures, more fluoroscopy, more contrast volume as expected. Now, the clinical outcomes at 1 month, and again, this is not power for clinical events, but it's nice to see that there is no compromise, numerically even lower rate of events if you don't treat the side branch, if there's no balloon inflated into the side branch. So per procedure MI, the primary endpoint was 5.7 if you treat the side branch versus 4.1 if you don't treat. And this is very highly significant for non-inferiority according to the trial design. As for the other endpoints, like target vessel MI 5.1 versus 3.7, again, no comp if you don't treat the side branch, but longer term follow-up, it's definitely necessary to assess what will be the clinical impact of this strategy, but so far it appears to be very safe. Now coming to the second part of this short presentation, we also have some interesting features from the Resolute Onyx DES. So this is a well-known device, well representing the new and generation DS that we use in our clinical practice. So I would highlight the conformability, the side branch access due to the zigzag design that you can see here, and not much link connectors. You can really expand this to a very interesting capability in terms of the opening of the side branch osteon. Also, if you're dealing with a 4.5 or 5.0 millimeter stent, you can go up to 6 millimeter, which in some more larger, especially left domain anatomies, this is a very desirable feature. Here, look at the opening of the side branch. So you can, if you recross into the side branch, you can have really a quite large opening, a 5.0 diameter. So if you're dealing with a large circumflex osteon, you recross and you do a kissing balloon or a balloon inflation, that you're really going to have a full opening of this osteon. And as I mentioned, this zigzag design without compromising radial strength, that allows you to overexpand to up to 6 millimeter for 5 or 5.0, and also have this kind of opening of the side branch. And here some other feature. This is also available for smaller vessels. So really a device with good features for bifurcation stenting. So with that, I will finish here my
Ricardo, for the
comments
presentation.
about the device. So Alejandro, you represent Medtronic now and have a lot of experience also in bifurcation PCI, as you work for many years in the cath lab. What do you say? Is there a comparative study now with Resolute Onyx against other new generation DS? I have to say they are very comparable overall in terms of clinical outcomes. Where do you see this device can really make a difference for a left main or a complex bifurcation?
I can do a T or whatever, but
Thank you for that presentation. I think that is very interesting. I'm going to answer your question first, and then I'm going to add some comments regarding the KISS trial that I think that it's very thoughtful. So regarding your question, I think that Resolute and these platforms that allow this expansion of the stent over the size that was originally designed allow us to treat bifurcation more comfortable. Because we can choose, as Lucio said, the diameter of the stent distally of the side of the main branch, but then we can perform a pod knowing that maybe a stent for 4 or 4.5 could achieve up to 6 millimeters of diameter in case specifically that we're treating the left main. So I think this is a very nice thing. The other nice thing is the short length of the stent, that you know that it's a kind of problem when we are overexpanding stents, that maybe this deformation could make that the stent shrink, and this could change a little bit the length of the stent, and also we could compromise the length of the stenosis that we're treating. So I think that this could be a very nice, interesting thing. And the third is that this possibility to wide open the struts and to get a very nice access to the side branch, as we saw in the first case that Lucio performed. It's a very nice thing too, because it allows a better flow and it's not obstructive to the side branch. Regarding the KISS trial, I wanted to ask you, what do you think about this topic that we're talking regarding this results in terms of the the criteria that they used to decide not touching the side branch. Because as you taught me when you were my professor at Dante Pasanese, the less that you touch, the less that you harm. So what do you think about this? Do you think that this is a technique that maybe we could incorporate, or do you think that maybe we could have a little more data regarding this?
Yeah, Alejandro, I think that's a very important aspect about the design of this trial. Before, and you remember that very nicely, we did not like to don't touch the side branch. We like to have an optimal angiographic result. We like to do kissing balloon. We wanted to have, full opening, and we are very worried about achieving an optimal angiographic result into the side branch osteon. That has changed due to studies with clinical endpoints and studies like BBC, BBK, BBC1, BBC2, Nordic trials that demonstrate that if you don't have a significant lesion to begin with, and if you have at the end of the procedure, a good flow without a major bifurcation compromising the flow, or a major dissection compromising the flow, or a very significant stenosis, residual stenosis, and FFR studies have correlated that above 85% by QCA, that's where you found a significant correlation. There was no significant clinical impact at the end of the long-term follow-up. Even Nordic 3 that compare kissing versus non-kissing in bifurcation lesions, not complex, it's important to say, they found that kissing balloon had less restenosis, but that did not translate into clinical benefit. So nowadays, with better devices like the Resolute Onyx, which is really a great platform for bifurcation, and with all the knowledge we have and the optimal techniques like this stepwise approach for provisional taught by the EBC group, I think we are very fine to only touch the side branch if you really have to, and you have to know that you're more likely to need to deploy stent if you dilate, if you do a kissing, if you do a single dilatation, if you do, whatever treatment there. So I think the message is that if you don't have any flow compromise, if you don't have a very significant stenosis, if you don't have a more dangerous dissection, it's okay to live like that, and the patient can do just fine. That's what we are doing in our clinical practice. So in the meantime, we had a few questions here that I think we can address. So, en el caso de finalizar con kissing balloon, ¿qué tipo de balones y qué referencia utiliza para elegir su tamaño de los balones? So I can take that one. You should use, if possible, short balloons. They should be sized according to the distal reference. Non-compliant balloon is the ideal combination. So if you have a 3.0 distal, like the first case that Lucio did, 3.0 millimeters, the distal main vessel, 2.5 millimeter, the side branch. So you should use a 3.0 and a 2.5. It can be short balloons. If you have that, like 12, 8 millimeters, okay, because you want to address mainly the osteum of these branches. And you don't want to, you be just, inside the carina or the main vessel or the proximal vessel, not much inside, just enough to really achieve a full dilatation of the osteum of the branches. So you don't have to do a kissing in the entire body of the proximal main vessel. It's just, enough, maybe 3-4 millimeter, it's okay. So you don't deform too much and overexpand the level of the carina and the proximal main vessel. The second question, esta técnica de no predilatar la rama lateral no iría contra las técnicas con DK crush? Absolutely. This study KISS is only for provisional approach. And we have learned that in the DK crush series, the potential benefit of this technique, and I would say for any double stenting technique, and when you have really more complex anatomies, long lesions, diffusely disease, very severe stenosis. So these are side branches. They're more likely to occlude and be compromised during procedure. So I don't think a provisional approach is a good idea for these cases. And then you should consider to predilate, prepare the lesion, deploy first the stent into the side branch, and then you have your stent in the main vessel. So that way you are sure that you're going to have continuous flow and access, not access exactly, but continuous flow into the side branch as you do your technique. So DK Crush has been developed because you want to really take off the risk of losing an important side branch. And that way, first you reconstruct the side branch and then you do the main vessel. That way you have continuous flow and no chance of occlusion. Alejandro, I think we can maybe move to the second case, right?
Yeah.
We still have a,
like
we have a
to
great
point out
audience
that-
following. Yeah, go ahead.
Yeah, I would like to point out that DK Crush is a double stent technique. And we are talking here about provisional stent technique that is just a single stent. So this no predilation of the side branch is just regarding the provisional stent. That is one single stent. In the case of the two stent technique, the predilation of the side branch is mandatory in most of the cases.
Yeah. So Lucio, do you hear us? We don't hear Lucio. Maybe if
You're
can
on mute,
get-
Lucio.
Can give
Yes.
back the
Mute.
audio from the room.
Now we can hear you. Now we can hear you. Yeah.
Okay, so Lucio, we still have a great audience following the cases. We have up to more 45 minutes for this second part of the demonstration. We already discussed the KISS study and also some interesting features of the Resolute Onyx Frontier. It's already available in Latin America, Alejandro, the Frontier.
Yes. It's been launched in many countries in Latin America, and there are many countries that already have that. Yeah.
Okay, great. So Lucio, what do you have for us now?
We are now with another bifurcation with a different size. So we are in another case with a septal branch
Awesome.
with a very big branch. We're going to try to do OCT in the main and to size the side branch from the main branch. So we are trying to do that in order to know what to do. The side branch, can you see that?
Yes. Can you go a little bit deeper distally, maybe? Because it appears at the end of the screen. Yeah.
Hard to say.
So
What do you-
Lucio, you have two guide wires right now in the main branch, or what are you doing right now?
One in the main and another in a septal branch. The idea is to go there because we have some limitations with the angulation in order to progress the camera. So the idea is try to do something in that bifurcation, the proximal one, and to try to use the camera, you know?
That's good. Yes. Now we can see the bifurcation. Now we can see it, and we can see that the two guide wires are in the main branch, and now you're trying to go through the side branch.
Sorry?
Just wait. We can still get the OCT in. I'll just-
Okay.
In the meantime,
Paul.
maybe I would like to ask Paul, if you are there, Paul. Is there a platform, Paul, that we can? I know there's so many cases performed at Visible Heart in the last years, and so many experts have performed cases, showing all the features, the techniques, and the problems as well, and how Visible Heart has helped us to really improve the technique and the care of our patients. Is there a platform that we can have? I mean, the attendees can have access to the cases and to the
Get a new
demonstrations into the step-by-step?
Yeah, there's a number of different platforms that we've used, Ricardo, and I'm just gonna move the camera quickly. And one of them is really we've been able to put the Atlas of Human Cardiac Anatomy on there. There's a whole section, tutorial section on devices. There's a section on stents. And then on top of that, if you see this card, if you were to scan this QR code, these are free phone apps that anybody can download. And one of the phone apps is actually a stent app, where we actually have all these different cases on there. We have, DK Crush, we have TAP, Culotte, T-stenting, V-stenting, and those are done in the visible heart. They're done basically in swine hearts, but we also have stents that were micro CT'd from human hearts that were actually came to our heart library with previous procedures. And then Amanda was able to micro CT them, make computational models, and you can actually see the displacements of the calcium by the stents in these clinical cases down to a 15 micron resolution.
In there.
No, this is fantastic. I just scanned here your QR code. Could you do it again, Paul? Because I just did it. Everything is here. So all the attendees, Paul is going to show the QR code here, please. Scan and have access to a fantastic material. I have seen some of this material already, and it's really, really very didactic. If you want to teach bifurcation in your center, if you want to learn bifurcation, you should really use this material. Thank you, Paul. Really great. Thank you so much.
And there's just general anatomy there as well. And there's T-echo, transthoracic echo tutorials. And we keep having stuff all the time. So keep watching.
Great. So that's one question here, Lucio. I will ask you to answer this question. I also would like to make a comment based on my experience. But cuando tenemos intención de dejar una guía atrapada en la rama lateral, en técnica de solo stent, ¿hay alguna advertencia con respecto al tipo de guía a utilizar? Nuestro colega Freddy Loinas. Por favor, Lucio, su opinión.
Does that work? Otherwise, we'll have to.
I don't like to use polymeric wires or PT wires. I try to use core-to-tip wires as BMW run through that type of wires. I don't want to use a PT2, for example.
Okay. So yeah, I would like to make an opinion here. That's one evidence showing that a hydrophilic coated wire, if you're trapped and then you remove, you could have some compromise of material desymbolization. But that's another studies and a lot of experts, they recommend to use hydrophilic wires because it's easier to remove them. So it's a little bit of controversy here. In my own practice, I have used most of the times non-polymeric wires. I mean polymeric, not hydrophilic, polymerics. When I mentioned that could have some difficulty in the desymbolization. I use most of the cases non-polymeric, non-hydrophilic wires. Never had problems, to not removing them. As Lucio mentioned as well, the same thing. But it's also a recommendation if you're dealing with much calcified anatomy, osteo, side branch at the carina level, or the proximal main vessel, the bifurcation. Don't over expand your stent proximally, even if you're going to do a pot, because then you might have some problem trapping the wire, and that you can break a wire. So you can finalize your procedure, remove the wire, and then have some extra post dilatation in the proximal segment. But in general, I think these are the recommendations. I see one more question here.
we have right now?
Yeah,
Three guide wires. What are you doing right now?
Yeah.
Well, we have that bifurcation LAD with a septal branch, and the idea is to imagine that the septal branch have a disease in an osteal lesion, and we want to know with the OCT assessment previous to do anything, what is the size of the LAD after the septal branch, the first one, where is the wire, and then Amanda will going to tell us which is the size, that this is 2.6 after the septal branch. And can you show us in the septal branch, please? There.
Alejandro,
Can you measure?
that's one question
There-
here. Yeah, go
Amanda
ahead,
is
Lucio.
1.6 is the septal branch, and the LAD is 3 proximal. So the idea is
small branch.
2 millimeters septal branch,
It's a very small side
a very
branch.
small size. What do you think we have to do in this situation? For me, I don't know. I want to hear you. For me, that type of branch, if had a disease in that type of branch, that size of branch, I will be so conservative. It's 2 millimeters
Way up.
proximal. Can you show the OCT, please? Full screen. Full screen,
That is.
please.
This.
Are you? So
Yeah,
we are
we
distal
see
to the
very
septal
nicely.
branch.
Yeah.
We are distal to the septal branch. So there is two. We are going to measure again. Is 2.5 because we have full screen. This is the septal branch. You can see very nice imaging, but
Mhm.
we have 1.6, no more than that. And this is proximal to the septal branch, and we have 2.9. So we have this type of situation. For example, we have to think that the septal branch is disease. So is 0, 001 or 010 or 011.
Yeah.
I don't know. Are you going to do something to the septal branch or no? What do you think about that?
Yeah, well, I
We are-
think
we are-
the septal in this demonstration is just as a side branch of any side branch. I think in real practice, we are less likely to treat a septal branch, but we want to always leave it open, especially if that only the main one in the proximal LAD, we know that can cause severe clinical impact if occluded. But for the sake of this demonstration, Lucio, I was going to suggest watching your presentation about the LATAM BIF, the registry, LATAM bifurcation registry. The double stenting technique mostly used in the region is a DK crush. So why don't you consider maybe demonstrate to us a DK crush, the technique, and you can use the septal as well. I don't see any problem here.
Okay. So you can.
Yeah, with a 2.0.
I would like to
Yep.
share with you some question from the audience is regarding how you manage when the guide wire is trapped between the stent and the vessel wall. What tips and tricks could you share with us regarding this situation when you try to retrieve the guide wire and it's not possible because it is trapped between the vessel wall and the stent?
This time, this is this.
I'd like to comment, Lucio, about a trapped wire.
No, we did in the last case. The wire was trapped, and we simply opened the valve and we retiramos la guía que estaba atrapada, simplemente haciendo un esfuerzo de retiro en forma no brusca, sino viendo si la guía se retiraba en forma fácil. Hay otras veces que no se retira y en esa situación uno puede hacer lo que se llama anchoring balloon poner un balón distal al side branch y empezar con eso a poder tirar de la guía del side branch para en forma bastante molesta y suave podamos retirar la guía lateral. ¿No? Creo que no hay que tirar, creo que hay que usar, yo no me gusta usar las guías esas con poliméricas, pero bueno, son distintas formas de visualizar eso, ¿no?
So, Lucio, we see a stent here advancing. Can you tell us what you're doing?
This is a 2.18, 2.018. The side branch is no more than 18. So here we can do two things. Because of the angulation, we have a vessel of 3 or 3.5 proximal, and we have a stent of 2. So in this situation, we can go and we can see you are looking now with the camera how is the stent related with the ostium, and what about the size? Will you prefer to try to implant a stent, an ostial one, or will you prefer to go to the main vessel, to this stent that can go and you can oversize till 3.5? In my opinion, I will try to preserve the main vessel and to put only a short one stent there in the ostium, if the ostium will be diseased. But
I think in both situations, that's a lot of things to learn. So feel what you want to do and just tell us the step by step and the problems and pros and cons for dealing with a small side branch. I totally agree with you. In real practice, stenting the small side branch is never a good idea. And maybe you can show us why.
In my practice, I will use, if I have to use, because it's a bigger side branch, and I have to do a double technique stent. This, what I say previously, have an angulation that is not so bad, so we can do a T-stent technique or a tap, and try not to compromise the main vessel. But this is a demonstration meeting, so I have now a balloon in the main branch.
It's 308. 308. Then do the crush later.
38 in order to do a crush after to develop this. No,
small.
It's very small. Yes, you can see that.
Yeah,
I would prefer.
We can see now the stand, and we can see the balloon also at the carina. Yeah.
Better the
a longer one
camera and to have a longer balloon. I will never do this with a short balloon. I will never do this. A crash.
3020,
yeah. Even the results for the DK Crush series, any side branch below 2.5, results are not that good. So we should avoid using this technique for side branches 2.5 or below. It's a really good technique for large side branches. But nevertheless, for the demonstration purposes here, it's very nice to see from inside how they behave.
In real life, I will never stent this side branch. Real life, never.
Yeah, just keep it open.
Because all that you have said, Ricardo, but we are now in this amazing cat lab, and we are trying to use all the things that we have. We are going to think that we have a bigger side branch, but we have an ostial lesion that isn't good result with the balloons. So we are going to try, and we don't have a very big lesion in the main branch, but the side branch is big. So this end is not too long as this one. We're going to try to see, and I leave the stent just in the main branch because I want to see by the camera. Now I'm going with another balloon a 3-0 balloon in order to do afterward the crash. There you can see. So
This is 305.
3-0 balloon. So
So
the
Lucio, very
idea is
important if you're doing a DK crush, you should have always, before you deploy the stent, the side branch, you should have a balloon parked in the main vessel, right, at the carina level.
yeah. So the idea nowadays is if we deliver the stent in a main branch, afterwards we have to crash. First of all, we are going to deliver to 12 atmosphere. Afterwards, we take back the balloon and we're going to go to the balloon of the stent to 18. Afterwards, we take that. Afterwards, we're going to do a crash with a balloon in the main branch. So we're going to start with that. So what about the camera? We're going.
Let's go step by step here.
Balloon. This is the crush balloon.
Just to say, here in the chat, we have saludos from Honduras, from Peru, from Mexico, from Argentina, from Brazil. It's really amazing, this event, take the whole Latin America, under the SOLACI umbrella. It's really amazing.
Bifurcation or have it more distal?
Or
Because
distal.
now we
distal.
can advance it a little bit. And I think it's really good to assess how much
So
protrusion
Lucio,
we want to.
yeah, exactly the point I was going to ask you, how much protrusion you have, and are you comfortable with that?
Yes,
Is this a mini crush? Is this a classic crush? What is it?
Yes, I will try to do. Oh, sorry. We'll try to do a mini crash.
A nano crush? Yeah, okay.
Yeah.
So you want to fully cover the ostium with minimal protrusion. But there is some protrusion. Also, here's saludos de Venezuela. So really many countries represented here. So, and then, just, okay, so you just at the level of the ostium of the side branch, we can see here from inside. Do you see the same thing by angel?
We think that we have 1 or 2 millimeters inside the main vessel.
Okay, so 1 or 2 millimeters inside the main vessel. By angel, that's what you see from inside.
Yeah.
Okay.
What do you
Very
think,
nice
Paul,
to
about
correlate that.
regarding the main vessel?
Good nano crush.
Less?
It's really a nano crush, exactly, Paul. Yeah,
This is now more of a
For me,
nano
it's a
crush.
nano. It's okay for me.
yeah. You
wanna
don't
go?
want to miss the ostium. Yeah.
Yeah.
Okay, so the stent is being deployed now. We can see nicely. You deploy stent into the side branch, which is a small vessel, relatively small vessel, and you try
Ricardo,
to
the idea is not too
Just at
high
the
pressure
ostium.
now for the beginning, and now to retire the balloon of the stand. Now go
now
and
high
to do
pressure. Okay,
a high pressure balloon,
okay,
18.
18, to
okay.
stay some time. Don't deflate the balloon very quick, because if not, the stand don't deploy. Deploy the stand. That is another take-home message. Don't do a 2 seconds insufflation technique. So
Okay.
I'm going to retire now.
So it's
The
really
bal-
1 or 2 millimeter here that we can see protruding into the main vessel. It's really what you see here.
Yes. Yeah,
It's like
yeah,
a mini
yeah.
crush. Yes. Yeah.
Yeah.
Okay.
So-
Very nicely. So Paul, you can really see go inside. Yeah. Very nice demonstration. Yeah.
So now we have.
So Lucio, I think that's an important point here. If you didn't have a balloon into the main vessel, to cross with a balloon could be a problem because you have struts protruding into the carina, right?
That's why we have this balloon
Yeah.
cross from the beginning.
So to do the first crush, do you remove the wire or you keep the wire?
For the first crash, in this case, I leave the wire, but
Yeah.
In the
I like to
flater.
remove the wire. Yeah.
yeah,
In the flater busted.
can you take this?
Yeah, I'll check this.
I'm afraid that can be trapped, into the struts, but yeah.
It's very
sometimes we
illustrative
forget.
because we could see that in the bottom side of the screen, there were almost no struts inside the main vessel. But as Ricardo said, when we're looking at the carina, then we can see that there are like 1.5 or 2 millimeters of struts. And this is why this is very important to have already a balloon placed in the main branch to avoid this problem to go through these struts that are protruded to the vessel lumen. Yeah.
Yeah. So Lucio, one very mechanistic question, because you have seen this debate in trials. To do this first crush, should you have a balloon size according to the distal reference of the main vessel, or is like a pot? You just do like a pot size to the proximal size of the vessel to do the first crush. What do you recommend?
For me, I recommend the side from the side branch to proximal.
Okay, so it's like a pot, the first pot. I agree with you. Okay, so nicely see. You see the crush of the stent here, just at the level of the carina. Very nicely seen. So it's like we call the neo-ostium of the side branch. So now, yeah.
The wire, I'm going to try to change the wire because I have some problems with it.
The tip, the tip, it's
with the tip. So
that happens in real life.
we ever need to have a plan B, B. So I can do this, and I can take the other wire to the proximal.
Yeah.
So maybe in the meantime we can take this question. So Lucio or Ricardo, what do you consider to choose the balloon for the crush? I understand that it's related to the main branch balloon. So what size do you choose?
Yeah, we just discussed this point. Well, one way to do it is you just have like a balloon across the bifurcation, and then you have to size according to the distal reference of the main vessel, because otherwise you can cause dissection trauma to the distal vessel. However, you not get a full crushing because you undersize to the proximal segment. So if you want to be very accurate, it's just like a pot. You take the short balloon, size to the proximal main vessel, and then you position as a pot, and then you do the first crush. And then you can have like a first crush, a first pot, a second pot, and a third pot, which is a repot in the cases. So Lucio, I see you advancing here a wire into the side branch.
Yes.
Yeah.
The problem with this demonstration is the landing zone is not too big, so the wire is in, we are in, but the floppy wire, so I leave the other wire in order to take it back.
Okay, so the wires were trapped, so you remove the wire, and now you're recrossing one by one. But in real life, just to say, the benefit of this technique is that you preserve the patency of the side branch all the time because you have a stent there. So if you have a very, very high risk side branch for occlusion, for compromise, a significant large side branch, that's a technique that will help you to preserve the patency throughout the procedure.
As you see, we don't have reflow, you know? Real life.
Oversized.
Oversized stent, small side branch, demonstration.
Yeah. So what you try to do now is to advance more deeper the wire into the side branch so you have enough support to go with the balloon. Is an extension catheter an option here, Lucio? Could it help you?
Yeah, maybe, but the problem here is that we don't have a good outflow. So if I do a pot, a kiss, a repot, blah, blah, and I don't have a good outflow in the small branch, like Houston, we are in a problem.
Yeah, so we have a wire now, we can see in the upper part in the main vessel. You have a wire
I'm going to do an angio to see what happened now. What is the outflow of this? You know what is? So if we have a patient, we need to preserve the patient. First the patient, second the other thing. If I have in the real life this result, I will live like this because I don't have outflow. We are trying to
absolutely,
reproduce
absolutely.
a simulation.
Yeah, I have a message here from our colleague Mario Zuniga Ayala. He's saying that he's not been able to see the images, Alejandro, only the audio. I don't know if that's a local problem, but maybe the IT guys can help us here.
Yeah, because we are seeing my screen is displaying all the cameras. Maybe it's
Very
something
interesting.
in the connection
Get your
of Dr. Mario. Yeah, solo audio. Yeah, but,
Look at the
in
wire.
the image we are displaying the cameras.
Yeah.
Dr. Zuniga. Yeah.
Alejandro, can you see the wire?
Yeah, you
Just
see,
go in.
Yes. Oh
Yeah.
yes.
Can you-
Yes.
this is things that can happen in real world, my friend. And then
But this is
you get the wire strapped in.
this is a new wire. Can you see this?
Yes.
Yeah.
Can you see?
It
You
was
see-
while you were trying to reach out distally, right? Of the side branch.
Yeah,
So Lucio,
yeah.
if this happens, if you have some difficulty maneuvering, what do you recommend? Just remove the wire and go with a new one?
Move the wire and go to my house.
Yeah, yeah. I recommend,
this-
you
in
know, don't force too much because you can end up with big problems. Yes. Wires
If
can
we
go
want to
around,
go
they
to
can go around the struts and they can really incredible things
Right.
can happen.
Sure.
So, would
Yeah,
you
another-
consider to perform a better crush with another balloon inside the main branch, or you are comfortable with this result in the side branch?
I'm very comfortable with this, but if you want to do another, I don't want to damage the main vessel. That's for me is the number one. Then this is a demonstration. We try to do this. We have the result. For me, I'm not going to do nothing in this side branch. If you want to, we can go to another side branch to do more things. But in my criteria in this side branch, I don't want to touch anymore the main vessel. I like the result for this. We are in a demonstration, but if you want to do something else, we can do it.
Oh, very clear the message that you're sharing with us. And I think that maybe if you have a nice flow in the main branch and you just have a little side branch with this stand in the ocean, maybe this is enough, and you're not going to
From
make
the
any difference treating the
from
main
the
branch.
beginning-
Yeah.
From the beginning, we said that the main branch, the side branch was small, but we're going to try to do these things. The message is for the future. If you have a side branch, a small one, I will do only balloon if the side branch is really symptomatic for the patient. But this type of side branch, I will never
You're an
touch.
angio here. Go ahead.
That's one message. The other message is to maintain the main vessel very good. In this case, that I have that type of dissection or the contrast in the distal vessel, that may be a perforation.
Looking at
or-
This up here now.
I will leave that.
Oh.
If you want me to go to another side branch, I can do it. We are all the team
Yeah,
is
Lucio,
very.
but I think that's very nice message. You know, we are seeing in real time here the difficulties on maneuvering and stenting small side branches in bifurcations, and if you want to move on, you know, the complex technique, this is what happens, you know, many times in real life. So I think you're showing us why. You're showing us the difficulty, you know, on positioning, on advancing, on having the wire, you know, with enough support. And then if you want to crush a small vessel, you know, to reaccess, how difficult it is, you know, wires can get trapped, you know. And you're right, the main vessel, the name already speaks for itself, you know, that's what you should focus on. And small side branches, it's very, very, not say never, but rarely you're going to see let's say, a patient with clinical, very severe angina or clinical limitation due to a small side branch with disease. So I really think that's a nice message that you are delivering here. And
I think that it's very nice case
understanding
too.
why.
Yeah, it's very
right.
teachable and very nice case. And I think that
Your
the main message
RCA
here is that
There.
this happened in real life. Yeah.
Yeah.
So
Let's
we
do
had
this.
a question. We had a question in the chat. It was regarding if always after kissing balloons you should perform pot. So I already answered. Yeah, you should.
Yeah.
And yeah, and I think that we all only have to thank Lucio and all the team in the Cat Lab for this amazing presentation. And we could go ahead with the final remarks, Ricardo.
Yeah, I think was really amazing, to see and to discuss and to learn a step by step, with everything that the Visible Lab in Minneapolis can offer. You have your pumping heart, which is that's a setup there, and as Paul already mentioned, the hearts from pig model, they are very similar to a human heart in terms of size, in terms of the distribution of the coronaries and all of that. So what we are seeing here, it's basically what we will be seeing if there's a human heart. Of course, there's no disease here, but we can learn from the techniques, from the wiring, from the step-by-step procedures. So really to thank Paul and his team for one more amazing demonstration, which teach us a lot, and that at the end will translate into benefit for our patients. And I think that's the most important thing. Also, congratulate Lucio and his partner for really
Feels good.
superb technique, step by step, and all the discussion, from someone who is really well experienced. And thank everybody who has been with us for these last 2 hours. I saw messages from all over Latin America, Alejandro. It's really amazing. And a lot of friends and a lot of colleagues, who take advantage of this session. And to thank Medtronic for supporting this event. I hope we can do more. We have a lot to learn for all of this. And finally, SOLACI for, putting this program together, and really to continuing and improving the education for our region, which is very important. And to thank you, the co-moderator. It was really a pleasure. Thank you so much.
Thank you. It was a pleasure of mine. Thank you, Dr. Lucio, and everybody at the Visible Heart Laboratory. And I will give the final link to Dr. Lucio to close the webinar.
Oh,
Yeah.
cutting out. Did they stop?
Lucio, can you hear me?
Oh.
Perfect. We are
Okay,
just
so
trying to go to.
I'm giving you the chance to close the webinar. So thank you for being with us. And it was a pleasure, very learned experience. And then you can close the webinar. Thank you.
Thank you to all of you. In order to see us, it's a pleasure to be invited to Paul and all the team here in Minneapolis and Medtronic to support this. So this is an amazing thing that we can learn a lot of things. I still learning. I love to learn. I love to be in these educational meetings. So don't hesitate. Don't hesitate to ask Paul and the team to come here to see, to investigate. There are a lot of things, not only coronary, in a structural, in a lot in the nervation, a lot of things. So try to maintain in touch with Paul and the team here in the University of Minnesota, and it was a pleasure to be here. And we are going to present all these things at EuroPCR. Les pido por favor a todos los participantes del registro que sigan y a ver si podemos llegar a los 2000 para mayo. Ojalá, Brasil está muy avanzado y hay que seguir. Me gustaría que todos puedan compartir la información para que puedan hacer abstracts o lo que fuere. Y hay que seguir publicando todo lo que se pueda para que nos puedan seguir viendo en el mundo y de esa forma saber lo que estamos haciendo. Es la única forma de mostrarnos, ¿sí?
Excelente, Lucio. Muchas gracias. Es una invitación para todos. En nombre de Medtronic, en nombre del doctor Ricardo Costa, el doctor Lucio Padilla, el doctor Iaizzo y todos el resto del equipo de Visible Heart. Fue un placer para nosotros acompañarnos. Obrigado a todos pela presença e a gente espera que tenha sido uma experiência muito educativa para todos. Have a good afternoon and see you in the next time. Bye bye.
Bye.
Thank you.
Thank you. Thank you.
Such a beautiful.
Nice.
Beautiful
The
water.
West, the best.
No, but
Do
it was very nice all. So I would never go to that
Hola a
sector in
todos,
my
vamos
life.
a continuar en vivo desde el lab para las personas que quieran seguir acompañándonos.
¿Alguien puede tomar las preguntas de la gente que va a seguir estando conectada?
Yeah. So we're continuing. We're going to do just a DK crush of this right coronary artery. And for sizing, because that's just way easier in the porcine model, we are going to employ OCT again. Because the fluoro images are double magnification, just to have a good idea of the distal reference. We're employing OCT.
¿Hay alguien que se haya quedado como para poder ver las preguntas? ¿Se movió el screen o? The screen is the same projector?
I think it's the same, but I don't know if the questions will get through to us. Is it going?
Yeah.
Okay.
Oh,
Oh,
no, it's out.
Yeah, then push with the balloon. You have to pull back the OCT a little bit first to straighten it out, and then
out of the opposite.
Can you go, this is the
we'll
balloon?
just you have to pull back so that it's sort of they're right next to each other. The balloon has to be right behind the OCT. That way you can advance it with the. I don't know if we can. Are you doing the OCT?
It's okay until the beginning.
Yeah, this is where we.
Pull camera back.
And you pull back the camera. Because angle.
So the reason we're having difficulty getting the OCT in is both the camera, but also that our OCT catheter has been in use for a while. There is a kink in it, so significant difficulty advancing it distally. But yeah, now managed to do it. Awesome.
Okay.
So again.
Bueno, estamos haciendo OCT para seguir si está alguno conectado. We're going to try speaking in English because we are here in the CAT lab. So first of all, we want to do an OCT assessment. Amanda is just looking forward. What about the right coronary artery after the posterior branch? Then to know the size of the side branch, and then to know the size of the proximal right coronary artery before the side branch. So we have distally 3.4. So it's a big vessel.
Yeah.
We are going to see what about the 4.5, 3.5, 4.5,
4.4, yeah.
and what about the bifurcation?
So the
Can
side
you-
branch is really hard to
side
see.
branch?
Maybe we should rerun it, and if we're lucky, it has changed the position a little bit.
But it's similar to the distal RCA angiographically, but
Yeah. Sometimes you're lucky and you get a different angle, but
so the idea is we are thinking that we have a two vessel disease, 111 Medina, and we have this angulated posterior ventricular branch. We don't want to cross there. So the idea is to put a stent, a decay crash stent technique from the posterior ventricular to crash, to do the pod, to recross. Sorry?
so the OCT is a little bit ambiguous in this regard because we don't know exactly if there's two branches or one coming off. but-
3.5 and 4.5.
But-
So
The side branch is hard to see.
Yeah.
okay, don't worry. We're going.
Maybe four.
Let's just go with a 4.0.
It's similar.
Yeah,
Going to take this.
both out.
So in this situation, we're going to choose a 4.0 balloon to crash and to put a 3.5 stent.
Yeah, I think that's good.
12,
So
it's okay.
first we'll do the 4.0 balloon.
4.0 balloon, no compliant balloon, and 3.5, 12, 15 stents.
Well, thanks. 3.5/12 stent, we
Yes,
got this.
for the posterior branch, and
4.0.
4.15, no compliant balloon. If you have
We have a
15 or 12,
12. We did try avoid touching the stent clinically.
eh?
In my clinic, some of the people were like, don't touch the stent with your gloves.
No,
Yeah.
I touch every time.
Yeah. I'm always,
No,
Only
because
touch
sometimes the stent moves, so I have to stop and to very few times, but
so when you put him on the wire,
yeah,
you touch the stent?
Yeah.
Because I don't
know.
know why, but
No.
people in my institution are like,
No, I do it.
don't touch it. It's very different everywhere, I guess.
We leave that. We put the
Okay,
other
we got the
balloon.
4.0. So they usually put the stent or balloon first. Now we twice
No.
hit the stent first, but clinically, would you put
If
first?
I
the main
have
vessel?
disease, it's pretty late. the side branch, the main branch. After I go with the stent, I leave the balloon distally in order to.
Yeah. Yeah, so the one that you used to
Yes.
pre-dilate the main branch, you just leave it in there.
So I leave the balloon distally that I will use to crash.
Mhm.
We put the stent more proximally. We don't want, so we have to do after that the pot, then to recross, then another pot, then to do a kissing, then to put the stent in the main, and finally. So this is a 4015 balloon. Here we can see what about.
We got stent and balloon in, now we need the camera.
Yeah. Perhaps you can be there.
Can't go in further?
Okay.
Yeah, we're waiting for you.
Can do a little angel, and
Yeah, that's a good idea.
that's all.
It does look good.
I think it's okay.
Yeah,
You have a little more contrast, Amanda?
we do. Yeah, we can do that. Can you pull back the guide a little bit in a second? Or you want to do it for the cine
I
first?
put back the stand. I think it's okay.
Yeah, looks good.
Go. Stand.
Wait, pull back the guide a little bit so we can see if we can get the camera down there too.
Put back there.
The guide catheter a little bit. Just-
Okay.
Yeah. So maybe Paul can also get the camera down there.
You can take the camera, Paul. Do you want me to?
Should we stent the way down there with the 5-0?
Yeah.
Oh, yeah, you're getting there.
We're just there.
There you are. This is actually more protrusion than I thought from angio.
Yes. Perhaps we need to do.
We go up here.
Just want to see that.
That was the wrong. I know, I was the wrong one. 12.
Go.
Now you say 18.
Yeah.
18.
You play.
So do you usually park the main vessel balloon on the carina or distally?
Distally.
Okay,
I
so
leave here
right, and then pull back.
and then pull back.
So here we can crush now.
Yeah. Yes.
Sounds
So,
good.
Okay, this is the question. No? If you do a single stent technique and the flow of the lateral branch is compromised and it recovers after dilating the strut, would you still do kissing balloon? In Spanish, si haces técnica de un solo stent y se compromete el flujo del ramo lateral y se recupera tras hacer dilatación del strut, ¿harías kissing balloon de todas formas?
sí o sí. Haría pot, haría kissing balloon, Y si el ramo lateral queda bien con balón, lo trataría de esperar unos minutos y si queda bien sin disección, haría balón con droga. Y si no tuviera eso, haría 2 stents. So we have a dissection.
Yeah, but it's minor.
Yeah.
It's just a thread.
Okay.
Okay, so we see the crushed.
Yes. We do the crash. We try to do with the same the pot. We do the pot.
Yeah, pot would be next. Now we can actually use the OCT as guidance for the diameter. So what was it? Was it
4 5 now. 4 5.
Yeah.
Yeah.
I think the rewiring would be easier after. Oh, yeah. Yeah.
We'll try to do this.
Use the introducer in.
If we cross, we'll try to go with a 2-0 balloon to do a kiss. Or if you
Try
have-
the used one, but I think it's
try to use
I think it
entonces
could also
antes del pot, después del pot recruzamos, do recross by the we are in, isn't it?
Mhm.
So we put the stent in the side branch. We leave 2-3 millimeters in the main branch. We insufflate at 12. Then we re-insufflate, but more proximally 18. Then we crush with a 4-0 balloon. We do pots. Now I have recross. I retire the wire from the side branch. I do the recross. Now I'm with a 2-0 balloon in order to go after the recross of the wire in the side branch. And that's what we do. We are in the side branch. We're going to insufflate now in order to open.
open. There's not a lot of, you can see that it's open.
Yeah, it's
Not
open.
enough contrast in there.
Lo podemos ver ahí en la cámara, se ve muy bien. I'm going to go. That side branch is 3.5, so we have to go and we have to do a kissing.
Yep.
So now next step to do a kiss, 3-5 and 3-5. And then we're going to put a stent, 4-0 stent, maybe 18, 22, whatever. 3.5.
We have another 3-5.
I use one,
Yeah, we have a 3-5-8. No, that's too short.
too short.
3-5-15. I think we had it.
It's okay.
Yeah, 3-5-15. So you're using it on the side branch. I'll go on the main.
Both. No? This.
Yeah, but you were currently putting it on the side branch, the new one.
I can cross.
Get your video. Camera one.
So
I
we
can
have to
cross.
dilate with a larger than a 2-0. Or you use a 2-5.
You have a 2.5 there?
Yeah. This was 3.5.
We pre-delete with a 2.5.
I think we should use one that we wasn't opened yet, so we can get through the struts. Yeah.
Compliant.
No, 256 is fine. Doesn't matter if it's short.
So the idea, we try to go with a 3.5 balloon. If anybody is there, we couldn't go with a 3.5. Previous pre-dilatation with a 2.0, and now we're going with a 2.56 millimeters to the posterior anterior branch. That cross very nice. So inflate 18.
18.
Deflate. Inflate.
20.
Deflate. The vessel is 3.5, so now we retry to go with a 3.5 balloon and to do a kissing. Better.
Yeah, we should be able to get through this.
We have to do this bifurcation in that case.
Yeah. Oh, we're still there.
So if somebody is there, now we are trying again with a 3.5, 12 millimeters non-compliant balloon to the side branch. The idea is to do a kiss after a new pot, then to put the stand in a bay branch. So
Look at it, they're hitting
we have
deformed it slightly. I was interested.
Yeah, the stem.
we are now in the oh perfect. If you have any question, just tell me, please. Thank you. So now we are in the posterior anterior branch. I'm going
We still have to get the main
yes,
branch.
but I need to do this because I had some problems to inflate this.
Wow. Okay. Problems advancing or?
Yeah, that's it. I will try to go like this.
Yeah.
And now I'm going to advance the other balloon.
Also
They're trying to do
3.5.
a very good kissing 3.5, choosing the size balloon by the distal diameter. So now I advance the posterior anterior balloon, not to bother the other balloon of the. Look at that.
Pushing out the guide a little bit. I think it doesn't want to go past the camera. Is that?
Maybe the camera. No, but it's here.
Oh,
Can you retry a little the camera? No, I don't know if you. No, it's okay. It's okay.
Good.
It's okay.
you want to then re-engage the guide as well? Or you want to first do the kissing?
Yes. We do
Side?
this. Side.
Then main? You want to reposition?
We are going to do kissing. Now the main. And now
Oh,
both at 12.
12.
So the main goes more to the distance, so we're going to retire more and go this way and this way. Both those 12
12.
deflate. So now we need to repeat the pots
bit of dissection.
Yeah, it's a longitudinal dissection from their kiss. That's off. That happens. That's the classic.
We want that.
Yep.
Pueden ver ahí la disección que se ve por el video. Ya sabíamos que iba a pasar. Es lo que sucede habitualmente cuando uno insufla con balones, aunque sean no complacientes, para tener
yeah.
un buen kiss.
What do you mean by long? 28?
Do you have the
Do you still have the what?
four balloon to?
Yeah, 40. Got it right here. 4015.
Can you see for a 40 stand 22?
I think we're on a new 40.
Oh, it's okay. You can use.
I know. Yeah, 406, 408, something like this.
Oh, balloon, you mean stand.
That would be balloon.
For
yeah.
a pot, do you have any balloon for
Yeah.
pot?
What? This is
Okay.
for what? So I have a 408 non-compliant.
If you can
balloon.
see in the video,
For the
you can
pot.
see what about the dissection created by the kissing balloon that we do.
Wait, it's exactly the section that we see in the other.
Now we need to do the second pot. After this, we're going to put the stand in the main across the posterior branch. So now we have the 40 balloon. We can do the pot now. Can you see the balloon, Paul? Yes, huh?
Paul? Yeah, Paul.
Okay.
Increase the light on.
Can you go deeper or to see?
Try and inflate pot.
Yeah. 18.
18. Strange, but
Yes.
this is
The
always
contrast is the
the
contrast.
contrast
Maybe the contrast.
waning.
But the balloon is
Yeah.
okay.
I'll just put more in now.
So we're going to take and leave this for pot, and then we're going to put. We're going to leave this.
Yep. Sorry.
Yeah.
Well, we'll cover
It's
that.
because we're going to cover now with the fan. Entonces hay 3 pots en el DK.
What's the length of that?
Sorry?
What?
26.
Fine. For this section as well.
So now we have a 40 stand from proximal GP or PD. And we'll cover the dissection, isn't it, Paul? I saw there the dissection. Can you remove a little the camera because we're going to deploy the. Okay.
The guy.
On your diaphragm. And can't move the camera. That was, I think your stent has to come back slightly right there.
Yeah.
It's okay for me. It's okay.
But we don't have all the dissection covered, or do we?
I think so.
Okay. We deploy here.
Yeah.
Sounds
Go.
good.
Well,
12.
now we're going to do a pot to go to 18. We can go now.
Huh?
Go.
18?
No.
No.
With the 40 balloon,
Right.
the shorter one.
Yeah.
If not, we're going to create another section.
Well, it depends if we're going outside of the stent or not. But this will be You're not going to get a different tweet. Cath lab. You want yours?
I love the other valves. If I don't have, I use what I have. No.
Yeah. I don't assume you're going to be switching to OCT.
Uh,
I think the images are really good, but especially for something like OCT, CTOs, you need something that's a little bit more sturdy.
there are some CTO that I can do it just with angio and stem bush.
Yeah,
It's not
it's not a.
what I want, but okay, there. We are doing port 18 for
18.
deflate. So we have to go more proximal port and again. This balloon is different to the other because they have
Oh,
less
Dr.
shoulders.
Padilla, we have another question.
Say,
Do you think of the proximal optimization with kissing balloon inflation technique for some two stent techniques?
for me, after the port, we need to do a kiss. But if you do a kiss in balloon technique and after that you don't do a pot, you can leave the proximal part of the stent deformed because the kissing balloon deformed the stent.
That will be oval.
An oval, yes. So after kissing, you need to finish with a pot. You can see now. We can see now. Some things.
Yeah. So I think what we nicely demonstrated is here that we had to use multiple inflations with the short pot balloon. And I think it's really important to have in mind what the shortest lengths of the balloons are, especially also in the provisional technique. Because if you do if you stent over your side branch and only leave 4 millimeters on the proximal end, you'll have a hard time doing a pot because there's no pot
So
balloon that's 4 millimeters.
Can you show Paul now? Less a cap.
Perfect.
Can you put can you show the camera bed? Nice. So we can see Wolbury post the stent here, the proximal part with the dissection at 3 o'clock. So this cover.
We still see the jailed wire.
And now this we have the 2 wires. Very nice case.
Yep.
You can see that we have the guiding catheter.
This is the guide and this is the camera.
Yes.
Yeah, you can move the guy back.
Do you want me to move the? That is the way. I'm going to try. If you can show, it's okay. If not, it's okay too, because very nice.
They're on the right.
So now next steps would be to recross the side branch.
To recross the side branch after the pot.
The jailed wire going in there.
Yeah. Now we're pulling out the jailed wire. And this is, I think this is a moment where you always have to look at the guide catheter, so it's not
I
going
cross
into the.
as a knuckle to distal, and then I will try to go and to do by the distal parts the kissing. Do you have the rotator? So now
Yes.
I'm crossing to the posterior branch. Again, the idea is
They're very
now I recross to the posterior branch, and now we are going to do keys and the final pot.
I want to do,
3, 5.
you think you're gonna get,
Sorry?
you think we're gonna get the balloon through the
No,
strut?
no, a small
Yeah.
one.
Yeah.
No, a small one, and then to do. Nikki, can you tell the people that continue filming this?
It's
Nice,
it is being recorded regardless.
recording.
Yeah.
Yes. $60. Thank you very much to all you guys and women to be with us at this time. It's an honor for me to be here with Paul, with all this team. I appreciate all the things that they are doing here. Any more question? ¿Alguna pregunta más? Háganla porque las estamos leyendo y si las podemos responder, son bienvenidas. Estoy tratando de ir con el balón 1,5 go, 18, a predilatar porque recruzamos. Ahí lo ven muy bien al balón grabado, desinflado. Ahora vamos a ir al otro, ahí estamos. Inflado de vuelta,
18.
18. Y ahora vamos a ir con un balón con el sizing adecuado, hacer un kissing y terminar con el pot. Si podemos ir con un 3-5 o un 3-0-3-5.
Antes utilizamos el 3-5.
3-5 o 3-5.
Sí.
Si se puede usar ese, ideal. Si hay alguna pregunta,
Sí.
ahí Paul nos está mostrando
Don't you think we can
cómo
use
está
the
bien
camera?
aposicionado, está cubierto la disección creada por el kissing balloon, que es algo que ya sabíamos que iba a suceder y que sucede y que uno quiere que pase eso, ¿no?
3-5. We'll just try the same one we used before. See if we get it through the.
So now the idea is to do a kissing again, as the DK crash technique says, and then to finalize with you can
Uh-huh.
see
Ah,
perfect. It's very nice. This
that's a used one. Yeah.
that's a used balloon and crossed very well because we do a very good plaque preparation and the struts were open. Eh?
Yeah.
So now we're going to put the other 3-5 balloon. We're not going to be so aggressive, only 12 atmosphere. Yes, I cross, I take back. Here, one, the other. So I will start with the side branch. You can see that. 12. I deflate. Now we're going to inflate the main branch.
12.
And now we're going to finish with a simultaneous kissing balloon. Deflate. We have to stay some seconds to inflate because if not, we are not doing the
This is
kissing.
something you can see really nicely on the angioscope too, that it takes a second to inflate, it takes a second to deflate. Especially the larger balloons take a little
Yes.
longer.
So here in the video, we can see that we think that the balloon is deflated and it's not deflated as so. And now we're going to go with a 4-0 balloon in order to do the final pot. If you have some questions or final question, remarks or something, you can do it. Here is Paul and all the team. We're going to do the pot and the final video, angio and OCT.
Dr. Padilla, there is a question in the chat.
Okay.
Por favor,
¿Qué
¿qué
dice?
guías están utilizando?
That's
So this is a question that will not really relate to the reality. we're using a
Cougar.
hockey stick guide, but that's not something you would use. This is something that's very specific to the pig model that we're using here. So any recommendations we would give for our guides would not apply to humans. I mean, for the left, you would be using an EBU 3.5, and then here, I don't know, do you use an Amplatz for the right, or do you use a JR? For your right coronary arteries, what's your standard guide?
Sorry. For the right corner, I use GR. And for the CTO, then Amplatz left.
Just to get more back.
Amplatz right.
Amplatz right.
No, LA. Amplatz
Oh,
left.
Yeah, 0.75.
No, I don't have in Argentina. I need to use
Use one.
AL1.
AL1, okay.
And if not, I can do the plate. This one.
Yeah.
You're tired.
You're already inflated? This one's busted, I think. Yeah, we have to get the air out. Oh, we got it. We got it. Ah. It's pulling
That's-
air in from here.
Yeah.
The inflator is pulling air. We have to
Okay.
use this one.
So last maneuver, post 4-0 balloon until 18.
This is
The
18.
deflate. I think we have to go. Can you move a little the
camera.
camera, please, Paul? Because we need to finish the pot.
Good. I think this is just because of the foreshortening.
Yes,
If you look at
you're okay.
so this
Okay.
is where it would inflate. That way
So
we
the last. Okay. You can see the video how the balloon that we deflated 3 seconds ago is still there. The 4-0 balloon. So now, do you have the OCT?
we
Maybe
still have it. Will be tough to get in, but we have it.
it's live.
Well, let me not move the camera shot.
Yeah, can you show us?
Can you show the camera, Paul? If we can, it's okay. If not, we can see. Let me see. If to do a complete.
Oh, look at this.
Wow. Great. Miren cómo está la bifurcación, cómo está cubierto los stents. No hay disección a la salida. Está muy bien. Es una demostración lindísima. Vamos a intentar ver si podemos bajar el OCT. Pero ya hemos terminado. Estamos muy
Can we use this
contentos.
again? Try and push it with the balloon or try like this.
Pull the camera all the way. Camera's fine.
Okay.
Camera's up.
I'll put your guide. Kathy. Come on.
Yes.
I use a
There you go.
Vamos a intentar hacer el OCT. Lo que pasa es que lo usamos muchas veces. We use a lot of time the OCT to do the previous assessment, the post.
not just today.
So a lot of days.
Mhm.
So it's real work. I hate these valves. I go. Perfect. Estamos avanzando. Ojalá que podamos. Tenemos fe. We are trying to go with the OCT now. If you have any other question, please don't hesitate. We are trying to. We're going to take this.
Now we got it. Go down.
Acá estamos haciendo una maniobra tratando de que con el balón distal avanzamos el OCT. Pero fíjense cómo hay mucha resistencia. Vamos a intentar sacar el balón y dejarlo acá proximal. A ver si podemos avanzar. Ahí estamos avanzando hacia el ramo posterior.
Doesn't look
It's a very good trick.
not in the right position, I guess, but
Yeah.
so if you pull it back and then push the balloon all the way down, it will go into the main vessel.
Yes.
If you
Yes.
straighten out the OCT going
Yes.
through,
Go.
yeah, now. No.
Let's see if we can go from this vessel.
Yeah, the OCT just doesn't wanna, there's the king.
Fíjense lo que es, ¿no? El OCT como tiene su kinking, más allá de tener un balón.
Yeah, now if you advance the balloon a little bit further. Oh no, that's gonna,
Fíjense cómo proximal. Vamos a retirar, porque primero está el paciente, ¿sí? Así que
take the OCT out. Yeah,
Final angio.
final angio.
final
Good.
angio. This is all that we want. Ya sacamos la guía, final angio. Excellent.
Well, that's a good
Do you
final
want-
image.
Do you want to see another angio to see the distal vessels? It's okay.
No, I think we're good.
So
Nice.
nice.
Well, thank you.
Thank you for getting forward.
Bueno,
Then we'll wrap up.
final remarks. We find a better second bifurcation, the right coronary artery. Thank you, Paul, because of all the effort. Thank you to all the team here, Anthony, Amanda, my colleague here, George, and you, because all the effort and all the guys here. We need a beer now.
Yeah.
So thank you very much. Bye.
Surprised that so many people stayed on, huh?
Yeah, good cases.
Yeah.
Good